We'll probably just get started then. There's enough people on. So Rachel and I are doing our EBM talk on antimicrobial stewardship. I feel like a lot of people are aware of antimicrobial stewardship, but don't really know the evidence behind it or what programs are actually a part of it. I think when we think of antimicrobial stewardship, we just think using the right antibiotic correctly, which in a sense is correct, but there's a lot more to it. How do I advance the slide? What? Oh no. Okay. Okay. I did. I clicked on it. Okay, so we just have a quick case here that we'll come back to. So an 82-year-old female, past medical history of hypertension, presenting VR with confusion, decreased PO intake. UA suggests UTI. So what antibiotics should we treat with? I know it sounds kind of trivial, but we'll come back to it. And then does the following hospital's antimicrobial stewardship policy actually prevent development of resistant organisms? So we'll touch base on both those questions and come back to them. So our question essentially was, does antimicrobial stewardship work? Mainly on the inpatient population, that's how most studies were done. So that's kind of the population we're looking at. The intervention are antibiotic stewardship programs. And again, we'll go into more details of what those include. Comparison would be no antibiotic stewardship program or no organized program. Outcome is the main things that we looked at for evidence-based outcomes were 1, development of resistant pathogens, 2, mortality associated with them, 3, length of treatment and length of stay, and cost essentially gets looped in with treatment and length of stay. Shortened treatment, shortened length of stay, cheaper cost. So what is it? Again, it's using the right antibiotic appropriately. Any coordinated effort or program to encourage appropriate antibiotic use or to improve patient outcomes and reduce antibiotic-resistant organisms. Every antimicrobial stewardship program, including ours, puts out a document that essentially states the goals and how they're going to achieve those. Our program also has that. You can find it on the policies and procedures page from our homepage. So they get looped into 2 categories. They're either restrictive or enabling. Restrictive-based programs are rules that you have to do or have to follow, or else you get in trouble. So a couple of these things. So selective susceptibility reporting. This is the lab putting out antibiotics that only should be used. That's why you don't see like azithromycin listed on like a urine culture susceptibilities, because they really shouldn't be used for that anyway. So that isn't an option when they report susceptibilities. On formulary drugs, this is again inpatient side of things. I know a big thing in ours is it's either Cipro or Levo. You know, our hospital doesn't like using levofloxacin for anything. They'd rather you use moxifloxacin or carbapenem or something else instead of using that. So hospital pharmacies will not use certain medications. EMR integration. This is whenever you're scheduling and ordering antibiotics that require stop dates, make you think, just so you don't have somebody that's been on azithromycin for 10 days when they should have been off it in 3. And then power plans associated with specific antibiotics. Like daptomycin, you need to be recording CK levels every so often. So the particularly more toxic medications or narrow spectrum medications usually have a power plant associated with them. You just can't order daptomycin. And then ID involvement. Certain conditions, certain infections, and certain antibiotics require ID consultation. If you look up our antibiogram, it not only for our hospital, it not only shows the antibiotics and susceptibilities, but it there's a page dedicated to which conditions suggest an ID consult and what conditions require an ID consult. So some of those examples are going to be MSSA bacteremia or endocarditis. Those usually require an ID consults because they'll require ID follow-up in the outpatient. And then certain antibiotics, these are like your toxic and narrow spectrum antibiotics, like amphotericin. You're not going to order amphotericin on your own. You need the consult ID to do that. Or daptomycin, very narrow spectrum, just for MRSA, usually for resistant, expanded resistance MRSA. So that usually requires ID involvement as well. Enabling programs is kind of resources to help physicians choose what should be done. These are your antibiograms that come out every couple of years, show resistance for what things, for empiric coverage. Audits, these are when you get calls from pharmacy saying, hey, you're on this, culture results came out, can we do this? Or prior cases when you get a notification from pharmacy like, hey, we noticed that this person was on this, but they're discharged in the future, use this. Antibiotic timeouts is what we should be doing, essentially to look for culture results, molecular results, just so which should be done every 2 to 3 days approximately. Make sure you're looking at the micro tab and changing antibiotics as appropriate. So if you never looked at an antibiogram before, you should. This is from ours. It'll essentially list the organisms on the left and then the antibiotics on top, and then you can look at it. So like E. coli here, looking at the resistance rates for here. So like ampicillin and ampicillin sulbactam for E. coli is terrible. Don't use it. Even ciprofloxacin, they're actually pretty bad too. So even these work for outpatient too. So by all means, make sure that if you're wondering about resistance rates, especially locally, you know, especially if you're just doing empiric coverage, take a look at this. So overall goals, they're gonna, yeah, what's up?
If you go back to the previous page, can you just?
Oh no, what did you make me do?
Don't do it, don't make you do anything. You don't want to do it.
Okay, what do you want?
Can you just go over what those numbers are telling us in there?
Yeah, so these numbers essentially record susceptibilities. So percent resistances or percent susceptible. So like we'll take a look down here, E. coli. So 100%, 100% of cultures have shown that it, at least around here, E. coli is susceptible to I can't even read that. Amikacin. I've never used that. Only CIP. Yeah. So the question was from Kristen. She just wanted me to go through these, to go through the numbers and what they mean. So the numbers indicate percent susceptibilities from all the culture results.
Oh, the parentheses?
I don't know. Yeah, number of cultures, I think. Yeah.
Thank
So,
you. I appreciate that.
So 99 is awesome.
Yeah.
30, you're like,
yeah, even 50. It's like 50% of isolated E. coli cultures are resistant to ampicillin. Only 50% are susceptible. So don't use that. Yeah, so if I have time at the end, I'll show you where to find the antibiogram, like for our hospital, and I'll go through it for you. It shouldn't take the whole hour, so I'll make sure to go through where to find it and how to interpret it, what information is included, and so on and so forth. So goals, again, will vary by institution. If you find the antibiotic stewardship page on ours, it'll show what their goals are. Typically, and these are included in ours, typically there'll be one of the just multiple portions of these components of these that are thrown in. Optimize antibiotics use is probably at the top of every antimicrobial stewardship. And again, that's kind of a blanket statement. Improve patient outcomes, mortality, length of treatment, hospital stay, decrease cost. Monitor resistance, so that's for your antibiograms. That's a large portion of any antimicrobial stewardship program. Education, so that's where the audits and tools from pharmacy kind of help physicians make their decisions on which antibiotic to place and for how long. And then another big portion of it is nosocomial infection monitoring, hospital-acquired C. diff, ventilator-associated pneumonia, surgically acquired like cellulitis or joint infections, so on and so forth. So for evidence-based, doing kind of literature review, we took a look at these 5. So decreased length of stay, decreased antibiotic use or length of antibiotic use, decreased mortality, decreased treatment time, and then rates of multi-drug resistant pathogens. So Rachel will start these. I'll chime in just to add on a couple things as she's talking, but we'll go over kind of what the literature and evidence says for these goals.
Yeah. So we found several systematic reviews that looked at the overall effect of antimicrobial stewardship programs. We couldn't find a lot that separated out what specific antimicrobial things they did and the specific effect of those interventions. I think because a hospital can't just do one thing for antimicrobial stewardship, it does have to be a whole program. So all of these results are basically doing a certain stewardship intervention versus not doing that intervention. And most of them were interrupted time studies. So overall length of stay, obviously the individual studies varied, but there generally was a benefit up to 3.3 days. And then the 2017 Cochrane review did find a mean decrease of 1.12 days. And these were all in inpatient populations. So overall does definitely decrease length of stay. And then decreasing length of stay kind of also goes along with overall antibiotic use. A lot of these were reported in tons of antibiotics used by the individual healthcare system. So I thought that was just interesting to think about, is we're using tons of antibiotics over time. But the studies did tend to show an overall decrease. One particular intervention that helped this with antibiotic timeouts. So basically, when you're doing rounds, like interdisciplinary rounds with pharmacy, especially taking a timeout, saying, is this person on an antibiotic? Are they on the right one, the right dose? When are we going to stop it? So those really do help to decrease antibiotic use. Computerized decision support, so kind of a similar thing when you're ordering a certain antibiotic, just having that little pop-up that says, is it appropriate? When are we stopping it? And then prospective audit and feedback as well, just again, having our pharmacy colleagues check in on us and make sure we're using these appropriately. Overall length of treatment, also again, going on with overall antibiotic use. So the actual number result on that was in the Cochrane review, a decrease of almost 2 days, which is pretty good. And then the de-escalation is largely guided by timeouts. And then another one that really helps with the de-escalation was the rapid testing, specifically for MRSA and other resistant isolates. So in this trial, when they implemented the rapid MRSA testing, they were able to decrease their vancomycin linezolid by 50%, which is pretty significant.
I'll talk a little bit about the procalcitonin guided discontinuation. So this is a portion of antimicrobial stewardship. A lot of us have heard about. It's one of those things that we all know that we should practice, but in actual practice, it's kind of hard to do because getting procalcitonins every day or every couple days, combined with how long it takes for them to get back, kind of cancels each other out. It has gotten better over the last couple of years for sure, but this is something to keep in mind. So 2 specific studies, ProRata and the SAPS trial. So they both had kind of the same criteria, discontinuing antibiotics after an 80% decrease from the initial procalcitonin, or if it reached less than 0.5 micrograms per liter. They looked at mortality and length of treatment were both the study endpoints. The pro rata trial was the first one that came out. ICU patients, they looked at mortality at 28 and 60 days, and then antibiotics 3 days instead of length of treatment. So that was kind of weird. So a couple things that were wrong with this one. It was a smaller study. They didn't really mix ICU, like medical and ICU surgical well, patient populations well. And their non-inferior mortality was set at 10%. So they said that essentially that meant that as long as the mortality of using this discontinuation guideline did not go above 10%, it was considered non-inferiority, not inferior to compared to not using procalcitonin guided. So in the pro rata trial, they actually had an increase in mortality in these ICU patients, but it was less than 10%. So they considered it non-inferior to not using procalcitonin guided discontinuation. The SAPS trial followed up a couple years later. It was much better. It was a larger study. They blended surgical and medical ICU patients. They set their non-inferiority guide to, I think, 8%. And this one actually showed reduced mortality. So not only non-inferior mortality rates, but reduced mortality overall at 28 days and 1 year. And then they, instead of using antibiotic 3 days, they used length of treatment, which was much easier to understand. So antibiotic days 5 for the procalcitonin guided. Mortality at 28 days was 20% compared to 25, and then at 1 year it was 36 compared to 43. So the SAPS trial was a much better illustration of the procalcitonin guide discontinuation. Again, the challenges are, how often are you getting the procalcitonin? How long does it take for the lab to return those values? And essentially, how well is the patient doing? So those were the 2 studies for procalcitonin guided. This is something, again, that's been kind of harped on for like the last 4 years, that this is something that we should probably be doing, but until turnaround times improve and you can get them regularly, it's hard to do. Another thing is cost. You're saving money by discontinuing antibiotics, but you're also using that cost for lab monitoring as well. As far as the mortality goes, that the SAPS trial definitely erred on the side of using this just for mortality basis. So at that point, cost kind of becomes a non-issue. Cost is equitable essentially from using money that you would have put towards antibiotics into lab monitoring, but you have improved mortality, then that should probably be the way to go. So. I cannot remember exactly how often they did them. I want to say yes, they did daily procalcitonin in their ill patients that were getting antibiotics. So we'll let Rachel continue the goal discussions.
Yeah. And then one thing I did want to mention with the procalcitonin, a point that's confused me in the past is I thought it could be used as a guide for when to initiate antibiotics. That's never what it was intended to begin. It was never really studied as that. It's only meant to be a guide for discontinuation. So just in case anyone else was ever confused by that point. And then overall effects on mortality, there wasn't a whole lot of evidence that programs as a whole decrease mortality, but none of them have appeared to increase mortality, which is obviously also relevant. There were a few trials that showed that mortality actually decreased with de-escalation of antibiotics, but then obviously a possible confounding variable there is you're more likely to de-escalate your less sick patients. So they're probably going to have less mortality anyways. And then rates of multi-drug resistant organisms. A lot of the papers mention that this is very hard to study because it depends on so many variables, especially infection control, as well as antimicrobial stewardship, so your isolation, your hand hygiene, things like that. But several of them did show decreases in multi-drug resistant infection and mortality. They specifically looked at MRSA, imipenem and meropenem resistance, ESBLs, and several times there were shown to be decreased multi-drug resistant isolates and infections, but again, very institution dependent and also dependent on the overall infection control programs. So overall, the programs do work. They have to be tailored to the individual institutions and what is going to work for that specific place in that specific time. But when you're looking at decreasing overall use, length of stay, and length of treatment, just putting in place some of the interventions we talked about definitely do have a large impact, and there has to be physician buy-in for these interventions. Yeah, and no change in mortality and decreased rates of multi-drug resistance. So kind of back to our case, just when I'm thinking of myself in the middle of the night admitting a patient with a UTI, like what am I going to choose? Is it really worth my while to really go through all the time and effort it takes to find what is truly the best antibiotic for this patient? It really does make a difference to take that time and follow the specific antibiogram and clinical guidance that has been put in place for the institution. So yes, it does make a difference.
So we'll show you how to access that, just so there's no confusion. And if you haven't seen it before, well, now's your chance. So this is just the home page, the team portal. So what you'll do here is just sign in. Might be signing into yours. Okay, we're Dr. Rachel Townsley. So if you go up here, you just look up the Antibiogram. So it'll be the first thing that pops up. All Memorial Antibiogram. Okay. So again, there's no reason you shouldn't see this because I've printed out multiple copies and put them in the 7th floor lounge. So if you don't, just look. Okay, so this is the first page you'll see. So this is what I was talking about when it will show or tell you which conditions and which infections are recommended to have an ID consult and which are required. So some things that recommended it, MSSA bacteremia, MRSA bacteremia, again, because they're mainly going to have extended IV use, outpatient, they'll have to follow up outpatient, which they're going to follow up with the ID docs. So that's what's recommended for them. Any E. faecalis bacteremia, again, should be consulted due ID, again, because they have a lot of VRE rates. So that would be the main concern for that. Let's see, let's do some of the required ones. So getting down here, these are things that require ID consults, mainly because we don't know how to interpret them. These are molecular tests that show like signs of resistance, expanded resistance. So if you're getting gram-negative resistant markers in a susceptibility report or a culture, make sure that you have to call ID for that. And again, it also, if you're, I'm not sure if it says here, I know daptomycin right there, they say that they should. There have been a couple times when I've had amphotericin need to be used, and that requires an ID consult as well. Pretty much anything. Anything, if you're getting yeast in a blood culture, you should probably call ID. All right, so these are the antibiograms themselves. This is kind of the meat and potatoes of it. Again, these are small, so I'm sorry, Kristen or Dr. Steiner. And this is essentially for empiric use, okay? This is before culture results come back, or if you're unable to obtain a culture. This is where you have to think back to more second year medical school when you're thinking of what organisms cause what diseases. For our case, she has an elderly woman with a UTI. Most of the time, that's going to be E. coli. So pulling this up, going to the gram-negative portion of it. And again, I'm sorry for those that are looking online and being like, what is he pointing at? I'll try to go through this as well as I can. So first you'll have the gram-negatives. Okay, you'll look up E. coli, which is right here. You'll have a long list of numbers. Each of those numbers is associated with susceptibility percentages for each of these antibiotics listed up at the top. So for E. coli, some of the things that we think of are going to be like what, Warren? Yeah. So I know in medical school, like we're always taught, like, oh, if they have a kidney infection or something, we should be giving them fluoroquinolones. Fluoroquinolones here actually have not the greatest susceptibility pattern. So only 76% of E. coli isolates are susceptible to fluoroquinolones, at least in our areas. That wouldn't be the best idea. Rocephin, yeah. So even I can't see these. I'm sorry. So yeah, ceftriaxone. For E. coli, it's 90% susceptible. So again, that's not even that's not great, but by all means, that's better than those. Zos. Zosyn and Z-Pak, yeah. So going through azithromycin, this is one of those things where they're not reporting susceptibilities for azithromycin because you shouldn't be using it for UTI. So yeah, meropenem is 100% susceptible. Next, yeah, piptazo is 95%. Nitrofurantoin, if you're convinced it's just a bladder, is 93%. So those are all effective. And again, the list goes on and on. Gram positives, gram negatives. So just going through a case that I had a couple weeks ago, I had somebody come in with multiple abscesses, had failed Bactrim, so we were concerned that it was MRSA, and we needed to replace her for antibiotic therapy. So one of the things that we came up with or looked for were, Bactrim, she'd already failed that. Clindamycin or doxycycline would be the next option. So I pulled this up. I looked up clindamycin for MRSA. It's terrible. It's only 67% susceptible. So I did not send her home with clindamycin. Instead, I sent her home with some tetracyclines, which right here, 96% susceptible. So again, these are generated from inpatient isolates and inpatient cultures, but you can apply them to outpatient practice. So again, think of what you're empirically treating, what bug you're empirically treating. Pull up the Antibiogram before you make any decisions. Just even if you're like convinced that, yes, I know what I should be giving, just pull it up anyway, because just because in theory it works doesn't necessarily reflect local resistance patterns. So that's that. Scroll a little bit lower, it'll give you some recommended regimens for certain antibiotics. Keep going down. They'll give you kind of some rules for, this is like the antibiotic timeouts. After 48 to 72 hours of empiric broad spectrum coverage, consider changing antibiotics based on culture in conjunction with that.
Can you do like that real quick, Dylan?
Yeah.
Does it show the price of all these antibiotics?
Yeah, so David asked, does it show the price for the antibiotics? So this is the approximate acquisition cost. So how much it costs the hospital, not necessarily the patient, but how much it costs the hospital to acquire, not just administer, but how much to acquire that drug for. So yeah, it'll give you the rough estimate of how much it is. Austin?
I was gonna ask another question. You can go back up to antibiotics. Look at azithromycin. Go list of months covers for pneumonias.
Let me see if it's where is it? I'm blind here.
It's already at 50%.
I don't see azithromycin. I see erythromycin.
We need to adopt the.
I don't know where is it.
What I recall is I talked to Richard one time, and he said that it's the nice in our area covering the levels pretty close to 50%.
Yeah. Yeah, so what Austin's saying, he had asked about azithromycin resistance patterns, and I can't see them here, but we've both talked to Richard Luger before, and essentially he's talking about strep pneumonia resistance patterns for azithromycin, and it's close to 50%. So it is pretty terrible for empiric coverage for pneumonia. Now that's different than if you're doing, COPD exacerbation, or if you know that it is a walking pneumonia or an atypical pneumonia, then that's different. But yeah, it shouldn't be used for that. Let's see here. Keep going down. There's another thing that I wanted to show you. These. So these are the commonly used medications, and it goes through desired empiric coverage, spectrum of activity. So these are just as useful as the antibiograms, I think. So it'll go through azithromycin. It's mainly for gram-positive, but again, that's a little bit iffy. It's typically used for atypical. So desired empiric coverage, atypical pneumonia. As trianam, cefepime, it'll tell you if it's gram-negative, gram-positive. Some of the more resistant type bugs like VRE, MRSA, Pseudomonas. It'll take you through a lot of different antibiotics. So again, if you're wondering what, this is more so if you're wondering what specific antibiotic covers what. So like clindamycin,